All right, everybody. Well, thanks so much. My name is Pete Marzano, and welcome to the Nuvasive Virtual Spine Conference. Very pleased you could join us today for an interactive discussion on complex spine revision considerations with our faculty, Dr. Steve Ludwig.
Thank you. Let me get my screen shared with everybody. We could begin. I think the goal here is to look at more complex spine situations and really understand the decision-making that goes into when we're going to treat these patients surgically. I think some of the most complex decisions that we're making here with regards to revision spine cases are probably some of the hardest decisions that we make collectively in a shared decision-making platform with our patients. And I think when we're dealing with simpler revision situations, those simpler problems essentially can be done almost immediately on the spot. But when we're dealing with more complex revision situations, when the stakes are a bit higher, and when really can influence somebody's life significantly, that approach needs to be vetted out very carefully, as I'm sure you guys are all aware and you're learning. I think when you take two steps back and you think about what you're going to do to the patient as we go through a couple of cases tonight, what I think we need to do is sort of think about what our goals are for our patients, right? And what the pros and cons of the approach to achieve those goals, right? Every decision that you make to do a level or to decompress something or to do an osteotomy, do it in the front or in the back, has pros and cons for everybody. And hopefully some of these cases will illustrate all those pros and cons. I think at the end of the day, what we all need to understand is that when you're dealing with complex spine problems, often complex spine problems require complex solutions, right? And complex spine problems that require complex solutions often have complex complications. So at the end of the day, I think what we need to do is sort of understand our limitations, understand the institution where you're practicing in, understand what your resources are, understand what it can do to your reputation, right? When you take on and tackle these problems, especially when you're first starting or when you're in your first several years of practice. So hopefully this can be interactive. You'll tell me what to do. I'll give you my experience and let you know what my thoughts are. So at the end of the day, right, there's multiple considerations here with regards to the decision-making as we talked about, right? You have to consider the whole bandwidth of different issues with regards to the patient's anatomy, their previous surgery, right? What kind of hardware, how you're going to get fixation, what you need to do, what your capabilities are as a surgeon, right, coming out, what your institution's capabilities are, right? All those play a role in your decision-making with regards to complex. So let's just start this off, and I'm not going to pick on anybody. Once again, this is almost should be a free-for-all. So once again, we're going to learn off of each other, guys. So this is a case that I had done, gosh, it must be at least 10 years old. And at the end of the day, I would do things a lot differently compared to the way I did it, 10 or 12 years ago. And that's an important point as well. So this is a 42-year-old woman that came in from St. Elsewhere. You could see her BMI is relatively normal for our neck of the woods. Her biggest chief complaint is bad, severe, progressive, intolerable, right? Low back pain in the low back area. It's made worse with activity, right? It's mechanical. Neurologically, she really has no neurologic symptoms, right? Her biggest issue is she can't really stand straight upright. Let me go into a little bit more that's pertinent for this. As you could see, she had previous surgery done multiple times. Her history stems back to 1989, where she was involved in a motor vehicle collision, sustained what it looks like retrospectively, probably a burst fracture with a flexion distraction moment that wasn't adequately reduced, but was fused sort of in situ. Fusion failed, had a revision of that, and then underwent a Harrington rod compression type of implantation to get fused, right? And she did okay. I think one of the other pertinent parts of her history that's important for everybody to understand is that she had an X-lap, right, done from xiphoid down to pubis in a midline sort of approach, just so that sort of goes into her previous history to take her spleen out as a result. So back pain, inability to stand upright, had an extensive bout of conservative management, right? She can't walk. She's a good host. So let's look a little bit at the parameters, just so we could sort of all be on the same playing field. So when you measure her out, you look at her pelvic incidence, about 56 degrees, right? Her lumbar lordosis is only 3 degrees, and her PILL mismatch is fairly significant, right? You got a 60-degree mismatch. You can see she has a significant retroversion of her pelvis, right? She's tilting her pelvis back to compensate 33 degrees, and her SVA is, almost 10 centimeters. When you look at her standing x-rays and you compare them to her CT scan, I think the one thing that some of you may notice off the bat is she corrects a little bit, right? Does everybody see that? Air in the disc space is sort of your friend, right? You can sort of leverage that air in the disc space. And when they lie down, for their CT scan advanced imaging studies, you could see that she partially corrects through those degenerative deformities at L4-5 and L5S1. Does everybody appreciate that? I think that's an important thing to sort of take a look at when you're evaluating somebody with a sagittal plane deformity. And you could see at the end of the day, we have to understand that she's at her wit's end, right? This is a good host. She's otherwise healthy. She really doesn't have a lot of risk factors with regards to diabetes, BMI. She's not a smoker. She's relatively healthy at 42, other than her trauma and her previous spinal history. So with that said, I'm sort of setting up that she's a fairly good from a selection standpoint. And oftentimes with these revision cases, the decision to operate is more important than the incision, right? That's the first step, right? We have to choose from a selection standpoint who to operate. So I'm just going to throw this out there. And the first, Shaylin, are you still on, or did you fall off? You're down.
Yeah, I'm on.
What are your thoughts on this guy or this woman?
Yeah, I think it's interesting that she is able to correct to a degree on the table. So that kind of gives you an indication that there might be a degree of flexibility that you can take advantage of.
Yep.
First thing that comes to mind is looking at the sagittal balance and the flat back deformity. I'm thinking she might need some sort of osteotomy or some sort of corrective osteotomy procedure to kind of install more lordosis focally at that maybe L2, L3 level.
Yep. So yeah, that's this is, as you pointed out, we want to leverage the range of motion we're getting when just by positioning a patient, right?
Mm-hmm.
And then we have to figure out if we can leverage that, how much of a deformity correction do we need to do for a fixed sagittal plane balance? Excuse me. I don't know, Tyson or Matt, what are your thoughts with regards to next steps with regards to figuring out what type of osteotomy? Once again, your PILL mismatch is fairly significant, right? 60 degrees, almost 60 degrees.
I think you commented already on the air in the disc space, which means you might be able to get those to open up and get possibly interbodies in there, as well as doing osteotomies at those levels to be able to get a little bit of correction there.
Mm-hmm.
And then I would be looking at...
When you say osteotomies, are you thinking like type 1, type 2 osteotomies, posterior column osteotomies with A-lifts? You think that'll get you enough?
I would be thinking posterior column osteotomies. I wouldn't be thinking much about anterior and somebody who's had pretty significant abdominal surgery before.
Yeah. Yep. Yep. Yeah.
That could be an option down lower, but seeing all those surgical clips sitting midline right in front of her spine would make me a little nervous.
Yep. Yep. I agree. Anybody tackling this from an anterior approach? Anybody feel comfortable in Harrisburg or in Hershey? Who's helping you out with your vascular approaches up front?
Yeah, we have a very good general surgeon who's done a lot over the years. That's what it stands out to me. I think with those vacuum discs and the amount of correction from her upright films, and I think the other thing you can appreciate from her upright films is just the amount of pelvic retroversion and even her knee bend in trying to compensate for her sagittal deformity. I think trying to get, I can't tell from the extent of her abdominal surgery, but I think trying to get anterior interbodies at 4.5 and at 5.1, where I think the lordosis is most important before doing something posterior, I think would give you the best support at the bottom of what's going to be a long fusion construct.
Yep. Yep. So, I went back and forth, and once again, 10 years ago, when I was sort of more junior in my practice, my decision making was a lot different back then than it is today, right? And my concern, as you brought up immediately, and a couple of people already noted, was going back in through the front, right? Even though we know that she corrects really fairly significantly through those disc spaces. But doing an ALIF at 4.5, 5.1, right, in the face of a previous splenectomy, and where she has an incision from xiphoid to pubis once again, is concerning, very concerning, at least to me. I don't know how much scar tissue there is. I don't know if the ureters are all scarred down. I don't even know if technically our guys can access, 5.1 can be all scarred in, 4.5, but I could tell you some of my largest complications were in revision anterior spine work. And if we have some time, we can get to a case where I could show you some of the most catastrophic complications we've had with going in through the front again. So you got to really, once again, think once, twice, or 3 times about your capabilities. Really, for me, at least at our institution, how many of you guys do your own approaches, your ALIF approaches? Because I think we're talking about, for this, doing an ACR and ALIF approach at 4.5, 5.1. How many of you guys are doing your own approaches? Yeah, I mean, I think, especially in this situation, you have to know your limitations. And even with a spectacular vascular surgeons, you have to be very careful, with regards to, the iliocaval junction, the ureters, and not being able, spending 6 hours losing a ton of blood and not even be able to see the appropriate anatomy to get these things jacked up with a nice ALIF, which is a beautiful approach, in a more virginal spine, from an anterior approach. But that's not the case here. So, any other thoughts about corrective techniques? We heard about posterior column osteotomies. If you're not able to do ALIFs, anybody thinking about any other approaches? Dan, through the back to get anterior column support. Any thoughts about that?
Yeah, so at WashU, we do a lot from the back, although lately we've been doing a lot of ALIFs. So my original thought was 4.5 and 5.1 ALIF and ACR at 3.4 and PCOs at multiple levels with an open fusion in the back. That was my original thought if it could be done. But if I had to go through the back, then what we'll do is... Can I
ask you a question? Just walk us through sort of how you would do the ACR at 3.4, because I agree that would be a profound way of getting your correction, right? and a profound way of avoiding a bloody mess, right, through doing a posterior, either a VCR or a PSO. We'll talk about that shortly. But tell me about your workflow. What do they do? What do they do at WashU that they're teaching you?
So that would be my workflow in practice. We don't do many X lifts at WashU. We don't do any ACRs. So I have no experience with that here at WashU. We do some X lifts, but no ACRs yet.
Got it. From a technical standpoint, though, the ACR is a very powerful tool, right? Where you would, I would imagine the workflow, if you were going to do that, would be probably, even if this was a virginal spine, I mean, you could theoretically do an ACR at 3-4 and cut the ALL and put your implant in and protect it with some fixation, right, to prevent it from spitting out. And then simultaneously do a 4-5 lateral as well. And people are even talking about doing 5-1 from that lateral position as well, but that could be very complex and very challenging. There have been times in the past where I've done laterals at 3-4, 4-5. You could do an ACR, and to get 5-1 and really jack open that space, you would have to reposition and do another separate approach, right? So you're talking about almost 3 incisions, 3 approaches, repositioning the patient, at least 2 more times to get your approach done, which takes longer in the operating room, saves a lot with regards to blood loss, but I really like that approach, and especially in a virginal spine, right? And avoids a lot of the problems with PSOs. I know, Lou, you've seen us do a bunch of PSOs, and you've seen a lot of our problems as well. And there's no denying that our service is filled with a lot of success stories, but also filled with a lot of problems and complications. What are your thoughts on approaching this all through the back because of everybody's concerns up front?
Yeah, I mean, I definitely think that's certainly reasonable. It's going to be a bloody mess when you get back there, probably. So I think based off of our experience, that was actually kind of my first thought was to maybe there could be a way you could do this off from the back and maybe do some sort of, 3-column osteotomy, whether that's at L4 or whatever, but I think that's certainly reasonable.
Yep. And let's just sort of go with the posterior column osteotomy in terms of picking the levels. What's the pros and cons of doing a PSO L3? Would you do it at the focal part of the deformity, right? This patient is globally imbalanced, regionally imbalanced, and focally imbalanced, right? Any thoughts about going at the apical region of the deformity versus more distal with regards to your selection?
I think you could. It might be a little easier at L4. I don't know how far that fusion extends down, but but might be a little less bloody if you kind of do it at L4.
Yeah. I think to Lou's point, I think the fusion goes down to the L3 area, right? You can see that compression hook there, and the more distal you go with regards to your selection of osteotomy, the greater the global correction of your spinal deformity, right? And when you look at her parameters and look at the magnitude of correction you need, right? She's fairly off, her SVA is fairly off, and, her PILL mismatch is going to require at minimum to get that degree of correction, at minimum a PSO, right? I think if you're going to approach this all through the back, doing a posterior column osteotomy and just positioning where you're going to get another 15 degrees is probably not going to get you to, those safety parameters that everybody's talking about. everybody I'm sure is aware of sort of our goals, and our goals for matching up a PI-LL mismatch are almost now geared towards the patient's pelvic incidence, the magnitude of their pelvic incidence, and their age, right? I think hopefully most of you all have, this is the hot thing since over the past 10 years that so much work has been done on to sort of program in the proper PI-LL mismatch based on the patient's age and based upon the magnitude of their pelvic incidence. This is a 42, 43-year-old female with a moderate-sized pelvic incidence. You want to get this woman, right, the data's out there, you want to get her within about 15 degrees of her PI, you want her mismatch to be about 15 degrees to be within the acceptable range. So if you're going to approach this all from the back, you need a fairly aggressive pedicle subtraction osteotomy, even with leveraging the air in the disc space. So let's move on and let me show you what I did. And then I want you guys to cast some stones at this. Once again, this is something that I would have done completely different today compared to the way I did it 10 years ago. So I did everything through the back because as everybody alluded to, I was sort of spooked from the previous splenectomy, right? And doing a revision, XLAP approach for this. And went in the back, removed all the hardware, which was overgrown with bone, solidly fused. She did correct as expected with really good positioning, right? Getting the patient's leg up on the table, right? So on a nice positioning on the OSI frame and leveraging the air in the disc spaces. I did an extended PSO at 3-4 because the more distal, as we talked about, your choice of PSO, the greater the global correction. And I went down to the pelvis because it was a great, huge lever arm. My concern for pseudoarthrosis at L5S1 and my concern with breakage of the sacrum. And when you look at how we did okay, right? Any thoughts on this, guys, in terms of what I did? So once again, I did it all through the back. Did an essentially a PSO through L4. These were my correction parameters afterwards. I didn't do any interbody support at 4-5 and 5-1 and took her down to the pelvis. Any thoughts on decision-making for this before I show you what happens? Matt, Tyson, Shaylin, Dan?
What did you do to gain lordosis at 4-5 and 5-1?
Just positioning.
Any PCOs or anything?
Yeah, I whacked out her facet joints, but I could tell you in full transparency, as you guys know, and I'm sure you've seen before, and as I think Lou pointed out, these cases can be bloody messes, right? And back then we didn't use, who has any experience with TXA from a blood loss perspective? Who's using TXAs? Any of you guys?
Yeah, we tend to use that on the neurosurgery side at Maryland. That whenever anesthesia is comfortable with it, they're generally more familiar with the comorbidities that you would want to not give it for. But yeah, for anything that we're expecting big blood loss, they ask that they are able to give it and start it sometime, right after we make a decision.
Yeah. And I agree. I mean, TXA, I think, once again, we weren't using it 10, 12 years ago when I first did this case, but today, I think it really is tremendous. We use a gram up front loading dose, and then we do a mg per kilo per hour drip, and then we load them again at the end. But I think you have to, as you pointed out, you have to convince anesthesia there's no risk factors. She really didn't have any risk factors, cardiovascular disease, color blindness, underlying seizure disorder. Those are all contraindications that I've learned the hard way in patients that have developed thromboembolic events. And, you're trying to put your hands around exactly what causes it, but the TXA has to be implicated at some level. But to answer your question, posterior column type 2 osteotomies, essentially facetectomies. In full transparency, she lost so much blood, I wanted to TLIF her at the bottom and I had to get out, right? Because her pressures were getting soft. I had to get out, and I thought the correction was there, and I was happy. I thought I achieved my goals, and I didn't want to do any more harm. So I said, that's it, we're done. She got coagulopathic. We sent her to the unit. She got resuscitated, right? I think the correction parameters look like I did an okay job, I thought. You could see here sort of locally when we measured it, right? You could see how we restored her lumbar lordosis. But this is the bottom line about this case, right? She was in the hospital for 2 weeks. As I alluded to, I lost 6 units of blood, which aborted the case, right? I didn't achieve all my goals, which were to really, if you take 2 steps back, I want to improve her sagittal plane balance. I want to help alleviate her back discomfort and pain. And I want to obtain a solid biological fusion with the least morbidity, right? And the way I thought we could achieve those goals was through the procedure I did, right? I didn't employ TXA, right? I did not, today I would have probably, because we have spectacular vascular approaches, I probably would have consulted vascular surgery preoperatively because I know their capabilities and their expertise, at least at our institution. And doing an ALIF at 4.5 and 5.1 through a retroperitoneal approach, not transperitoneal approach, may have been an option with our guys' technical abilities. And it probably would have allowed me to do less work in the back through an osteotomy approach. But at this point, I lost 6 units of blood. I couldn't go on and do the TLIF for anterior column support. She sat in the unit, and she developed such a bad ileus postoperatively, she perfed her bowel, right? And on top of that, she had some quad weakness after I osteotomized her. And we worked her up, and there was nothing compression. I think it was just from the magnitude of the correction and a stretch phenomenon, which eventually got better. But I think a lot of lessons learned from this case that I would have done differently. It took me a long time to do that case, right? Because I was less experienced at the time. And I think if you guys are going to attempt these cases, when you first go out and practice, I think you need an assistant, right? A really good assistant. You really need a really great anesthesia group, and you need a really great postoperative management group as well. You got to mobilize these patients, right? They're all narked up, and they develop ileuses. You got to watch them very closely. And they once again, complex problems can have complex solutions with complex complications. I think if anybody had to predict, because the story doesn't end here, but we want to move on to another case. If anybody had to predict at 18 months, 2 years out, what happened to her and what she presented with, what intermediate term complication, anybody want to sort of throw a guess of what happened to her down the road?
I'd be worried about potentially pseudoarthrosis at 5.1 with no interbody in there and a large construct on top of it.
Exactly. Who said that? I don't know who's talking.
Oh, sorry, it's Matt.
Oh, hey, Matt. Yeah, you hit the nail on the head. Exactly. She broke a rod. She broke it at 5.1, and I had to go in and revise it. And you ready for this, Matt? And I don't know, we don't have the revision pictures here, but I did go in through the front and did a retroperitoneal approach with the vascular surgeons, did a nice ALIF at 5.1, and then changed the rod members out in the back and reconstructed her through the back. And she actually did very well after that as well. So that was a much more complex solution, even because she had another bowel exploratory lap because of her perforation. And I thought it was going to be a disaster, but it actually ended up being fairly straightforward, surprisingly. So any questions about that case? I know there's a lot of things moving in that case, but I think you get the picture that there's a lot of things that go into the decision-making. There's a lot of pros and cons with regards to our approaches. And there's a lot of different answers for that one case. Any questions?
Dr. Ludwig, I have a quick question.
Sure.
what are your thoughts on dual rod construct across the osteotomy site? Do you do that routinely or?
Oh my God, that's such a great question. I love that question because we did a bunch of biomechanical research. One of our fellows that's at NYU right now had that same question. So once again, this case, you hit the nail on the head as well. You guys are so smart. The way we do it now is we use at minimum 3 rods, at minimum, cobalt chrome rods. And to mitigate the risk of what happened to her 18 months out, right? 2 years out, the rod breakage and the pseudoarthrosis. So at minimum 3 rods, I typically will stack the rods right on top of each other. So the satellite rods, I like the short rod. So if the PSO for her was at L4, I would put a screw in at L3, a screw in at L5, and I would control my osteotomy across that short segment, put short rods. And typically what happens when you close the osteotomy, you sort of, the lumbar lordosis moves the apex of that lordosis anteriorly so you could stack the rods on top. And then I'll run another rod from the pelvis through the S1 screw all the way up to my more proximal points of fixation. I also, on top of that, I'll do a T-lift at L5, S1, because I don't want to come back and revise these. So my decision-making, once again, 10 years later into this, I feel like I'm much smarter than I was, 10 years ago. And it's just experience, right? What is your experience with satellite rods? What are you guys doing?
Yeah, so I mean, in fellowship for any type of like osteotomy closure, I know Manish Gupta is, published kind of big on this, that we'd oftentimes do satellite rods there, just in terms of if there was real risk or concern for kind of too much stress or tension with the correction focally at that level. But I think we've had pretty good results overall with that, and it's a pretty, I think, solid technique.
Yep. Yeah, and I think whether or not you do satellite rods right off to the side, or you can stack them, I mean, I think it works, whatever works best, right? But pretty much any deformity correction where I'm doing a PSO or a VCR, we are absolutely adding a minimum a 3rd or 4th rod. Great question. Anything else, guys?
Dr. Ludwig, before we jump into the next case, I was curious to get your thoughts on how you're reconciling intraoperative alignment now versus then, right? Like, what's your protocol and how's that evolved?
Yeah. So it's evolved, over the years. In the past, and I'll still do this, Enrique, and it's a real conundrum, right? You have a lot of software that's out there that you can leverage, where you can do a lot of, we didn't have the pre-op planning, right? One of our fellows sort of retrospectively was looking at a lot of our cases, and we were going back with a lot of the computer-aided software and looking to see how playing around how we did, right? So at the time when I did this case, we didn't have that software, those software applications. And a lot of it is sort of was estimating based upon using a goniometer and figuring out what we can get out of osteotomies, positioning, PSOs, right, and VCRs, et cetera. And to answer your question, in the operating room, we would get long-standing lateral views, right, for sagittal planes. And I'm still doing that. I'm getting lateral views, and we're doing measurements, and we're seeing whether or not we've achieved our measurement parameters, right? Nowadays, you guys make phenomenal software that makes the lives for these guys in the decision-making a lot easier, right? And a lot of that technology is available to allow you to validate, to your point, what your pre-op plan was and whether or not you've achieved that. So I can tell you that the guys that are fellows now have all that technology that is tremendously beneficial for our patients because of that.
Excellent, thank you.
Anything else, guys? Let's move on for the sake of time to at least one more case, and then you guys can tell me if you want to continue on or if anybody has other cases. But this is being at a level 1 trauma center, we inherit a lot of cases that we don't necessarily ever want to see. And this is an example of one of those cases. So this is somebody that came into shock trauma on transfer, and 67 years old. I put 17, but he must have had over 20 operations on his spine. A lot of them were initially for cervical myelopathy that developed into an infection, an osteomyelitis reconstruction that sort of went down the spine, requiring further extension. He presented to our institution after a motor vehicle collision. This case is probably about 8 to 10 years old. He had an open wound that was being closed secondarily and being managed at an outside institution by a plastic surgeon with local wound care. And after the accident, which was a fairly low speed motor vehicle collision, he had acute onset of pain in his thoracolumbar junction. And it's kind of hard to see in these x-rays. And this gives you an understanding of the magnitude of the reconstruction that was done, prior to him arriving with us. But as you can see, after the accident, you could see what he has here. This is the T12 level, where he had sort of a fracture through his pedicles and his vertebral body at his lowest instrumented vertebral body at T12. The way he presented to us was severe back pain, inability to get up, an open wound on his back. I'm sorry, I don't have the pictures of that, but it looked fairly healthy granulation tissue, just so you have some perspective on this. Once again, he had psoriasis that probably contributed to some of his development of infections in the past. But his complaint was inability to stand up, acute onset of pain after the accident, and neurologic weakness with his right leg worse than his left. So here's his advanced imaging study that we have. Any thoughts on this? Shaylin, Matt, Tyson, anyone want to take a stab at this?
Looks like he fractured, I guess, chronically. Was that like a T12 vertebral body? And then looks like there's medial plow of the screws there. I don't know what level that top left is. And some significant retropulsion within the canal posteriorly, right at the T12 level.
Right.
Makes sense in terms of his neurologic presentation and compromise there.
Yeah, he has almost a conus medullaris syndrome, right?
Yeah.
With almost like monoplegia, poor rectal tone, poor sensation, horrible pain, right? He can't mobilize. He does have also, and people don't pay attention, he's got a low-grade ischic spondy at 5'1". Just may or may not play a role in your decision-making. But any thoughts, Matt or Tyson? What your thoughts are on this?
Yeah, initially I was thinking it would be a good one to maybe approach laterally and do a thoracic corpectomy. Obviously, there are screws at that level which would inhibit your ability to do that. He fractured one level too high. So I think I'd print him the MapQuest directions to Maryland.
Any other thoughts? So are you approaching this? Are you going to go in the back and take his hardware out and then go in the front and then go in the back again? Or what are your thoughts? Does he need? What are your goals here for him?
No, I think you could do this all from the back. I think he's going to get a significant amount of correction on the table. I think that I would take out. I wouldn't take out all of his hardware, but I would take out distal hardware. See what corrections. I think the goals are The biggest is just thoracic cord decompression, and then stability. So I don't know that you necessarily need to go the whole way. You mentioned the isthmic spondy. I don't know that you need to go the whole way there. But I think you get enough correction. You can get cord decompression, maybe a transpedicular approach at that level, or a costotransversectomy at that level to decompress the spinal cord appropriately, and then extending him down to perhaps the L3 level or so.
Yep. Any other thoughts on, so that's one good option, right? So, once again, our goals here, as you pointed out really nicely, are to, help him with his neurologics, right? So he's going to need some kind of decompression, help with his stability, right? And correct his deformity, right? And what are your thoughts going posterior? Remember, he has an open wound, right? Anybody have any thoughts? This is like the disaster of the disasters, right? Like this is somebody that I'm going to either shoot up to Harrisburg or GW. Or Dayton, Ohio. Right?
Yeah, I forgot about the open wound. Yeah, that's.
Yeah.
What are you guys doing? What are you going to do in Dayton?
So I see as a little bit of retrolisthesis at L3-4. So I would be hesitant to stop at that level. This guy, he needs one surgery, and I never want to operate on him again. So I would probably take him to the
love surgery, right? He's had like 30 operations.
He's had he's gonna have one more, and that's the one I do.
Your goal is to decompress his conus, right? And then never ever to operate on him again, right? So I guess you're done with it, right? But do you think going too big is gonna, and he's got an open wound, right?
Right, and I mean, I think there are a lot of factors to consider. I'd like to see the wound. Is the wound up by his neck, or is it down by where we're operating?
Yeah, it's right. You ready for this?
Yeah.
It's perfect. It's right over where we're operating.
Of course it is, right.
And I'm not making this up, right? This is it.
Yeah.
Welcome to my practice.
Is he a really sick guy, medically sick?
He actually looks like he has a fairly good, when the oncologists talk about performance status, how good people look. He actually looks like this guy's a survivor, right? He's had multiple operations. He's had infections. He's had myelopathy. He's actually walking around. He's not working, but he's like a farmer. He's a good guy, which is bad luck. So I would tell you that he's very, very resilient.
I would consider just going going down to 2 and doing a lateral corpectomy. Get the reduction on the table, go down to L2, and then give anterior column support either through a lateral corpectomy or I don't really want to do much in the back, so I probably would not do a costotransversectomy at that level to give anterior column support. I'd probably go lateral second stage.
So you take the hardware out first? You'd have to take the hardware out somehow, right?
Because, yeah, and right. And you're going to go through his wound no matter what. I don't think you can fully stabilize him from just the lateral position. So
got it.
You're going to go through his wound no matter what.
No, I agree with that. Any other thoughts? Any other thoughts how long we should go, decision making with that, versus approaches, versus who are you going to get to help you out? Anybody consulting any other services for this?
Yeah, I would definitely have plastic surgery there to at least close the wound, if not explore it from the very beginning with you, especially if you're doing a posterior approach.
Yeah, 100%, 100%. This guy, the first and second and third service we're calling in for this is plastic surgery, because I agree, although this guy is a fairly robust guy, he would be it would be interesting to think about how to provide anterior column support, decompress them anteriorly, and extend them down through the front. But the wound is a significant albatross for us. Totally agree. So let me show you what we did, and then you guys can cast stones, at this. So I went in through the back, and I forgot who suggested this, but I did not take all his hardware out, right? That would be an even bigger operation, right? My goals for this guy was keep it simple, right? My goals were to decompress his conus, right? Put his conus in the best environment to recover his neurologic function. He wasn't out, but he was severely weak, and he had, once again, a conus medullaris syndrome. And I thought I could do that through a transperdicular type of approach. I didn't want to waste a lot more time and exposure and reconstruct his anterior column, so I shortened him a little bit as I did that transperdicular approach. And then I brought him down to L3 to stabilize him and give him the stability. Simultaneously, I did a massive debridement of his wound and had the plastic surgeons reconstruct him, right? And he was on suppressive antibiotics for the rest of his life. We got infectious disease to look at him. Postoperatively, he actually was fairly happy for a lot of reasons. One, he was standing much more upright. 2, his pain was dramatically diminished. 3, his neurologic issues were resolving, although he had a neurogenic bladder at the end of the day. And 4, he didn't have to do any of the local wound care. But he was on antibiotics, suppressive antibiotics as per ID for the rest of his life. He's probably about 5 years out. And then he came back to me, and it was like a nightmare. I saw him walking into clinic, and I vaguely remembered him. And then as he got closer, I remembered him again, and he presented to me with some clicking in the back. He felt a pop. He could still stand upright. And Lou, guess what happened?
I'm guessing he broke his rods, and he either has a pseudo or he's infected too, and he's looking for help.
All the above. All the above. So he came in about 3 or 4 years later. It was like a nightmare for me. And his complaint was that he felt this clicking in his back. He popped his rod, broke his rod. His alignment was good. He really wasn't in much pain. He was afebrile. Anybody going to operate on this guy for the 30th time? Anybody? Crickets? So, yeah, I left it alone.
I wouldn't have done the 29th time.
What?
Could have gone to the pelvis.
Maybe we should have. You're right, though. You're right. I mean, once again, no right or wrong answer, right? But everybody's going to see these disasters, right? At the end of the day, I think what you need to do is really deconstruct all of these cases, because there's a lot of decision making, and we, just spent, probably about 45, 50 minutes going through 2 examples of absolutely disastrous cases that we picked that reveal that you really have to think about the complexity of the case. You have to think about the anatomy. You have to think about the pros and cons of all the approaches. Alignment plays a crucial role, right? And the tools are there for you, right? You guys are all in your learning modes, and you're out there, and you really have to understand what your capabilities are. Don't be afraid to get help. Don't be afraid to get assistance from different services, right? We talked about vascular help. We talked about plastic surgery help. We talked about neurosurgery bailing me out all the time at my institution. I think really creating a camaraderie with those service lines really, really improves your delivery of care for patients. So I think that's really important to think about.
Well, any other questions, gang, for Dr. Ludwig? We're an hour and change in, and want to be respectful to his time and yours as well. Anything from our first 2 cases that ring a bell or spark some interest? All righty. Well,
Good.
Dr. Ludwig, thank you very much for today's discussion.
Thank you,
Really
guys.
appreciate your insights on revision considerations. And thanks for everybody joining us this evening as well. So thanks so much for your participation, your questions, and really wish you all very, very well in the days ahead. So thanks very much. Have a good evening. Take care, everybody.